Hey, what's up, Sacramento? Doc Mackey coming at you with the November 1st updates for the Sacramento County EMS agency. As we have done in the past, I have my partners in crime with me. We've got Dr. Nike, Dr. Smalls, and Dr. Sloan. Dr. Nike has got a special treat for you. She's coming from somewhere in the world, but I'll let her introduce herself. But I thought I would start out this video in front of the historic water tower, which is where the EMS division is. This is where all the brains and the operations of EMS for Sacramento Fire Department happens. But a little bit of history about this building. This building was built in 1939 under Franklin Delano Roosevelt. It's a federal water tower, and believe it or not, there is still water at the very top of this tower, and it's still a working water tower here in Sacramento. So when you hear us at the EMS division say that we're underwater, we literally are underwater. All right, so I have some good news for you. This November 1st update isn't full of a lot of changes. That's the good news. So we're going to use this as an opportunity to do some updates and do some reminders of the more complex policies and the policies we get questions about. But let's get this party started. I'm going to kick it off with our doctors introducing themselves. We'll jump right in with policies, and I'll see you guys in just a second. Thanks for joining us.
Good morning, Sacramento. This is Dr. Nike. I wasn't able to stay with Drs. Mackey, Dr. Sloan, and Dr. Smalls today, but I'm here from Hanoi, Vietnam, and we're going to be talking about 3 EMS policies from different places in Vietnam. So join me on this wonderful tour.
Hi, I'm Brian Sloan. I'm the medical director for Folsom Fire Department, and we're here at Station 35.
Hello, I'm Alex Schmaltz, Medical Director of Sacramento Metro Fire, and we are at Station 50 today.
All right, so we use this as our intro slide. There are 11 policies that don't have substantial changes, but the 2 here that we're going to spend a little bit more time talking about is 5053, which is trauma triage, which our beloved Dr. Nike will take us through, and then cardiac dysrhythmias, which yours truly will take us through. But let's kick it off with the next policy. Take it away.
AMA or elopement at a hospital. This is a circumstance that is coming up with increasing frequency with increasing wall times. Now, what do you do if you're already on hospital property and this occurs? First and foremost, you need to contact the hospital staff. Let a nurse or a physician know so that they have the opportunity to come and talk to the patient. Okay? Once the hospital has received the patient on their property, the hospital is responsible for this patient. You, as the EMS personnel, are not responsible for trying to hold the patient or change their mind. It is the hospital's patient, and they need to come and assess the patient and talk to them. Your responsibilities are to notify the hospital staff, the facility staff, and document who you talk to and when you talk to them. At that point, they should be talking to the patient and completing their AMA and elopement forms unique to their own facility. Moving on to extended APOT times. This policy creates a pathway for notification for when our APOT times become too long. If you find yourself on wall time for a prolonged period of time, you need to notify your EMS supervisor. While you're on wall time, first and foremost, check to see if your patient meets 50-50 criteria for being placed directly in the waiting room. As a reminder, you need to continue any cardiac monitoring that's in progress, make sure you're taking vitals every 15 minutes, and make sure to continue any treatments that were started en route or prior to arrival. Okay? Communicate those treatments with facility staff, but if the patient needs additional or new treatments, you need to make sure you communicate that with the facility staff, as the hospital needs to be starting those treatments. Also, make sure you communicate with facility staff and document in your PCR any deterioration, changes in vital signs, or other concerns. Very important that we need to talk about if the patient is deteriorating on wall time, that we identified it, we acted on it, we notified facility staff, and who we notified and what time. If you're waiting more than 60 minutes, notify your EMS supervisor.
So we are here at AMTN in Vietnam, and we're going to talk about policy 5010. And that policy is the transfer of care of a non-transporting paramedic to a transporting paramedic or EMT. There's a couple of things I'd like you to remember when doing so. The non-transporting paramedic must convey to the transporting paramedic or EMT all the important information on the patient's care, treatment, patient's response, so that the transporting paramedic or EMT can convey the information to the receiving facility. Number two, the transporting paramedic or EMT has to agree to the transfer of care of the patient. They can refuse if they feel that the care has not stabilized or adequately appropriately treated the patient or is out of their scope. Lastly, if a paramedic determines that you're transporting to an EMT or transferring care to an EMT, they are telling you that this is a BLS care patient and that BLS care will be provided. No ALS interventions will occur. I hope that sheds a little bit of light on policy 5010. Good evening from AMTN, Vietnam. Evening Sacramento, and what a beautiful venue to go over the Trauma Destination Policy 5052. We are currently at Hom Long Bay, Vietnam, on a cruise in one of UNESCO World Traveling Sites. So let's kind of go over initially what are the definitions of a trauma patient. A critical trauma patient is a patient that meets one criteria of the trauma triage criteria policy, which is policy 5053. A non-critical trauma patient is a patient that does not meet any of the criteria of the trauma triage policy. So let's go over the policy briefly here. I am going to utilize some notes to do this, but while I'm doing that, please take a look at this beautiful site that we're visiting today. So realize that any patient suffering an acute injury or suspected acute injury shall have the trauma triage criteria 5053 applied to that patient. Transporting units, whether they are by air or by ground, that are subject to any 911 emergency or non-emergency response should transport to the closest appropriate designated trauma center. If any medical oversight is necessary, it is essential and it shall be provided by the receiving SCEMSA agency designated trauma center that the patient is being transported to. So all pediatric patients age 14 and less shall be transported to the Pediatric Trauma Center, which is UC Davis. However, there's some certain criteria that divert from that. Number one, if the pediatric patient has an ineffective airway, they needed to go to the closest available facility for emergent airway establishment and stabilization prior to being transferred to the Pediatric Trauma Center. Second, pediatric patients under CPR shall be transferred to the closest trauma facility or center. If UC Davis is closed to pediatric trauma, pediatric patients shall be taken to the closest trauma center by time. Pediatric patients with a tourniquet need to be transported to UC Davis. Realize any patient who meets trauma triage criteria, has an LVAD, shall be transported to UC Davis. Well, hopefully that was a brief summary of we're going over the Trauma Destination Criteria 5053. Welcome to Hom Long Bay, Vietnam. It is happy hour now, so cheers.
Okay. Moving on to allergic reaction and anaphylaxis. BLS use of epinephrine autoinjectors has been added to scope of practice for BLS. However, to use an autoinjector as an EMT, you must have either received epinephrine autoinjector training from your agency or possess a CA/EMSA epinephrine certification. Right? So if the state has already given you an epinephrine certification, you can use epinephrine autoinjectors. Definitely defer to your agency and make sure that you've gone through the appropriate training and have the appropriate credentials to do so prior to using it. So moving on to one of my favorite parts of trauma, needle thoracostomies. Needle thoracostomies are an incredibly important, absolutely life-saving procedure. Over the last several years, we have noticed a significant increase in complications related to needle thoracostomies. So we think it's important to talk a little bit about them today and emphasize the importance of the appropriate patient selection and appropriate site for this procedure. Now, if you have any traumatic arrest, then an indication exists for bilateral needle decompressions. Whether it's blunt or penetrating, if your patient is in traumatic cardiac arrest, you can do bilateral needle decompressions. A small percentage of these patients who are in traumatic cardiac arrest will have their arrest because of tension pneumothorax. This is our one chance to reverse that almost inevitable death from a traumatic cardiac arrest with a procedure. The second indication would be unilateral decreased breath sounds and significant instability. That significant instability would be severe respiratory distress and or hypotension. I would also encourage you to look for signs of decreased mentation, low oxygen saturation, anything else that's going to tell you that this patient is in distress. Decreased breath sounds alone are not a reason to do a needle decompression because the patient may not have a tension pneumothorax. Decreased breath sounds alone are not a reason to do a needle decompression because the patient may not have a tension pneumothorax. If we do a needle thoracostomy on a patient who does not have a tension pneumothorax, it is not going to do anything beneficial for them. It is only beneficial if they have a tension pneumothorax. Many of the complications have been complications where the needle thoracostomy is put into either the liver, spleen, or intestines because the procedure is done too low. Your target site is either the third or fourth intracostal space at the anterior axillary line. What I tell my medics is that it's often much higher than you anticipate. A good approximation of your safety area is to take the patient's fist, put it into their axilla, and anywhere that their fist is covering is your safe site. So this is more frequently higher than you imagine it is. A needle thoracostomy done at the level of the mammillary fold or below is going to end up in the abdomen and you're going to have a significant complication. So make sure you're going high enough to get that appropriate needle decompression. Again, and as a pro tip, you can put a 10 cc flush on the end of your needle, put some of the fluid out of it first, and then put some tension on it as you're pushing it through the chest wall. And once you're actually in the thoracic cavity, you will get some bubbling in the syringe that will tell you you're in the appropriate place. If you don't have bubbling on that syringe, your needle is not in the thoracic cavity. It's either still in the muscles or you've gone into the abdomen and you're somewhere you're not supposed to be, especially if you get blood in your needle.
Okay everybody, policy 8024. This is a review. It's adult cardiac dysrhythmias, and we're going to talk about tachy and brady dysrhythmias because I like to remind you of this. This is a kind of a complex policy, but I think it's overly complex in our minds, but not really in practice. So let me walk you through this. You see that car on the right-hand side? That's just a reminder that you need an on-ramp to get into this policy. So let me start with that on-ramp. That on-ramp for tachy dysrhythmias that are unstable is a narrow rhythm greater than 150 or a wide rhythm greater than 120. But the patient also has to have signs of hypoperfusion, altered level of consciousness, ischemic chest pain, congestive heart failure, signs of shock like sweating or cyanosis, something like that. There's your on-ramp. But I want to pause. Okay, ask yourself a question before you're thinking about using this policy. Is this tachydysrhythmia a primary cardiac etiology, which may not be that easy to answer? But let me give you some examples of ones that are easy to answer. What if your patient's febrile and they're hypotensive? Okay, now we're talking about sepsis. That tachydysrhythmia is not secondary to a primary cardiac problem. That's due to sepsis. You should not be synchronized cardioverting sepsis. that has a tachydysrhythmia. We need to treat that with fluids, antipyretics like IV Tylenol, and transport to the hospital. But barring that, if it's a primary cardiac condition, let's try to do some things before we jump into the electricity side. If at all possible, try to get a 12 lead, start an IV, give some oxygen if needed, and then you can whisper in some Versed. Almost said fentanyl, but I meant Versed. Whisper in some Versed. 4 milligrams is the starting adult dose, up to 6 milligrams before you start delivering electricity. Now, let's get to the electricity part. The first shock in a tachydysrhythmia is 100 joules. Okay, if that works, we go off the off ramp. However, if it doesn't, you give a second shock, that's a 200. That doesn't work, a third shock at your maximal joules, and then you get to a fork in the road if it has not worked to this point. And I would like to offer you an opportunity at that point to change the vectors of your pads. It may not be working because the vectors of your pads are not placed appropriately, preferably anterior and posterior. Now that being said, if you're not successful and you're a wide rhythm, you're going to be giving them amiodarone push. If they're in a narrow rhythm, you're going to do your fourth shock. Okay, so it's shock, no success, shock, no success, shock, and then either amiodarone for wide or another shock if they're narrow. Okay? All right, now let's take a successful result. You've successfully converted the patient, okay? If they were wide, that's an amiodarone drip. If they were narrow, that's transport. So it takes this really complex policy and it all of a sudden starts to make it pretty easy, right? All right. What if the tachydysrhythmia is stable? Okay, so they're not hypotensive, they don't show signs of shock, right? But they may be an SVT, right? The only narrow, fast rhythm we do anything with is SVT. Now, patients who typically have SVT are young, probably have a condition that will tell you that they had SVT in the past, or they may tell you that they've had SVT in the past. It's a good time to ask them that. Now, if you think it's SVT, that's a good opportunity to do a vagal maneuver, and if that doesn't work, you can give adenosine. Any other narrow, fast rhythm you do nothing with until they become shocky, hypotensive, altered. Okay? Do not give adenosine to rapid atrial fibrillation. It will not work. Okay? They need something different than that. These are for the stable patients. Transitioning to bradydysrhythmias, the slow rhythms. You have another on-ramp. You have to have all three in this situation. Their heart rate has to be less than 50 on a monitor. They have to be hypotensive, less than 90 systolic blood pressure, and they have to show signs of hypoperfusion like altered level, ischemic chest pain, sweaty, cyanotic, diaphoretic, all of that stuff. They have to have all three. That's your on-ramp to using electricity to pace. Now let's talk about pacing. We want to try to get that 12 lead if we can. That 12 lead is incredibly valuable both in the fast and in the slow rhythms to not only your care in front of you, but also the future care. For the cardiologist, it's going to try to manage this days to weeks to months down the road. This may be the only opportunity that we get to see in the healthcare world outside your world of what this patient's rhythm really was. So getting that 12 lead is important. Get that IV, give them oxygen. You can give them Versed just like before, okay, but knowing that Versed is going to lower a blood pressure, okay, be careful with that. And then you place your pads, anterior, posterior is the preferred place, and then you start pacing. Once you start your pacing and you're dialing up your milliamps, you're looking for first electrical capture. This is so important. Electrical capture means that there's a pacer spike in front of every single QRS, every single one. It's not going to miss any of them. Once you've established that, then you check a radial pulse, see if you have mechanical capture, and if you do, you're in the lane, you're good to go, transport. Okay? All right, that covers the tachy and braided dysrhythmia or cardiac dysrhythmia policy for adults. I hope that brings a little bit of clarity of kind of the intent and the why.
So policy 8827 pertains to 12-lead EKGs. There's a couple of big pearls in this one. One is that if the patient's clinical status changes, repeat a 12-lead EKG. The other big teaching point here is that you should not get an EKG on patients until 7 minutes after ROSC. So if they've been under CPR, you got return of spontaneous circulation, you shouldn't get an EKG on them until 7 minutes after ROSC. And the reason for this is because you've given them all sorts of epinephrine, their heart also hasn't probably gotten enough oxygen, they've been basically underneath the most extreme of circumstances your heart can possibly be under. So your EKG is not going to show really what was happening before or what's going to be happening in 10 minutes. So oftentimes if you get an EKG before 7 minutes, there's a false positive showing a STEMI. And this might send you to the wrong center. You might not need to go to a STEMI center. So by waiting 7 minutes, you will be getting an accurate EKG that'll actually send you to the right center. So policy 8808 is about vascular access. The big changes here are that it focused on where you can put pediatric IO access, so pediatric interosseous access. The big changes here are that it removed the humeral access, the proximal humeral access, and added the proximal femur access as the third choice. The third choice is the proximal femur. There's limited guidance on recommendations on preferred sites in children, but there's a clear preference for IV access whenever you can. So if you can get an IV, go for the IV. If you can't, you always have the IO as a backup. There's literature about complications of IO access in neonates, so this is an important one. There is some literature about complications from IO access in neonates. So there's important parts about using the smallest needle, use the proximal tibia if you can, and then engage the drill after you reach access with the bone. So if you push that needle through the soft tissue and then you use the drill. Also, the insertion site will always be shorter than you think it's going to be in neonates. Policy 8069 is about a new medication called Buprenorphine. This is a medication that helps treat people who are addicted to opiates and who are withdrawing from opiates. This is an important medication for us. It's really important to note that opiate overdoses are the #1 cause of death in people under the age of 55. That's more than trauma, more than anything else. And it's also the #1 cause of years of life lost amongst all of Americans, particularly in Sacramento. One other important statistic is that opiate overdoses are the second deadliest event in US history. So opiate overdoses have killed more people than World War I, World War II, HIV, AIDS, the Civil War, all of those things. Opiate overdoses have killed more people. The implementation is going to vary based on each department, so I would really recommend looking into your own internal operations and your training in regards to utilization of this medication and this policy.
So moving on to cardiac arrest. This section has a lot of change, and this section has several changes that at face value might make you feel uncomfortable. My goal today is to take away a lot of that discomfort and let you know that these changes are based in science and evidence. You have a cardiac arrest patient that you have achieved ROSC on. First intervention is going to be to control their airway. Whether or not it's an eye gel or an endotracheal tube doesn't necessarily matter. The endotracheal tube is preferred, but if you have a good functioning eye gel and you're getting adequate airway protection, oxygenation, and ventilation, you don't have to change it. Changing it would be preferred if possible, but if you've got a difficult airway, a lot of emesis, anything that makes you think it's going to be challenging and your eye gel is working, it's probably best to just leave it be for now. The eye gel actually does a lot better than people expect it to. Second, manage your ventilations. One of the most important things that we do wrong in post-cardiac arrest care is overventilate patients. One of the most important things that we do wrong in post-cardiac arrest care is overventilate patients. It is very natural when you're stressed out after having done CPR and run a code or whatever to really squeeze that BVM thinking, man, this person just died, I should give them a lot more oxygen. But that's actually the worst thing we could do. In the immediate post-ROSC phase, when the heart has just started beating, that heart is dysfunctional. That heart is not moving oxygen and blood well. It's moving it, but it's still really sick. And if we inflate the lungs too much, we increase the intrathoracic pressure too much and actually make that blood flow back to the heart for the heart to pump forward a lot worse. We put pressure on the IVC, which doesn't allow blood to actually fill the heart, and we can make that patient a lot sicker and make them code again. So it's very important to actually make sure we're controlling our ventilations appropriately. Our target is 10 breaths per minute, which is a lot slower than we're used to. On top of that, we want to target their SpO2 somewhere between 92 and 98%. Your post-ROSC patient has a sick heart and sick lungs. If they're not 100% right off the bat, that's okay. If you can get them to 92% or higher, we're happy with that. They're going to be getting 100% oxygen anyways, but you don't have to overventilate them to get them to 100%. If they are at 92 or higher, let them ride, okay? Lastly, use end tidal, right? You should have put end tidal on all of these patients anyways if they're getting any type of advanced airway, but you can use your end tidal to help you guide your ventilation. Our target end tidal is going to be somewhere between 35 and 45. Can you rely on that in the immediate post-ROSC period? Probably not. The immediate post-ROSC period, you're going to have much higher end tidals because that patient is finally offloading all the CO2 they built up. So a few minutes after ROSC, when they start to normalize, target that 35 to 45 with your ventilations and make sure you're squeezing the bag just enough to get chest rise. Their problem at this point is not necessarily oxygenation, it's their cardiac output, and we want to preserve that by not increasing intrathoracic pressure too much. Very important. Also, manage their hypotension. A sick heart is not going to be working well. You're going to have pretty significant hypotension. That's very common. Manage it with IV fluid boluses and push dose pressors. You don't have to wait until you've completed a fluid bolus to give push dose epi. And I will tell you, at the hospital, the moment I get a ring down that I have a ROSC patient en route, I start mixing my own push dose epi to put in my pocket for when the patient arrives. I think it's an incredible drug and it works very well. If you have a post-ROSC patient, that patient is trying to die on you again immediately. They're already thinking about dying on you. And if you can control their heart rate and their blood pressure, it makes it a lot harder for them to die on you, makes them more stable, and is going to keep them stable enough for that heart to turn back on and start beating appropriately. So low threshold to use push dose epi in addition to fluids in that post-ROSC hypotensive patient. Also, wait 7 minutes to get your post-ROSC EKG. Why is that? I think the conventional teaching is you get ROSC, get a 12 lead, see what the rhythm is. See if it's a STEMI. Let that heart equilibrate a little bit before you get your 12 lead EKG. And there's reasonable data behind this. We may see something on that initial 12 lead in that pissed off, stunned heart that goes away after 7 minutes. And that could change the patient's course of care, where they go, the interventions that they get. Lastly, and this is a hard one for a lot of people to kind of process, try to wait 10 minutes before you move that post-ROSC patient. Why is that? Patients who die tend to die again. And in that pissed off, stunted, struggling heart, even small shuffling could cause them to go into cardiac arrest again. And with that, if you're moving a patient, if you're picking them off the floor, putting them on a gurney, loading them in the ambulance, all the things that you're doing, if they go into cardiac arrest again, are you able to perform adequate CPR? I think we would all agree, no, it's impossible. You can't do good CPR moving a patient. Most patients who are going to re-arrest are going to re-arrest within 10 minutes. And so if we can wait to make sure that they've stabilized, we can make sure that we're moving them when they're stable, not when they're coding. In addition to that, that 10 minutes gives you a lot of time to control that airway, get your 12 lead, make sure your IV access is good, switch to your ET tube, and manage that entire bundle of care. And I will tell you, there is nothing that you guys do that's really all that different than what we do in that immediate post-ROSC period at the hospital. I think it's a big convention change, it's a big mindset change to sit on your hands when you have a critically ill patient who just got ROSC, but there's good data behind it, there's a lot of other systems doing the same thing, and we really do believe it's the right thing for these patients. Moving on to shock. One of the major changes to our shock policy is that insulin shock has been removed. If you have a patient with hypo or hyperglycemia, treat them according to that policy. Insulin shock is not really a thing, and the patient is best treated with that normal hypoglycemia or hyperglycemia policy. In addition, some of the push dose pressor wording has been removed in the ALS policy here, but that's because it's just listed in other places. Push dose pressors have not been removed.
So policy 8044 talks about spinal motion restriction. The big pearls from this are in regards to pediatric spinal motion restriction. If the patient is less than 2 years old, you can keep them in their car seats, and that counts as spinal motion restriction. If the patient is greater than 5 years old, use an appropriately sized collar or a soft towel with tape. The mechanism of injury should really guide the spinal motion restriction if the patient is less than 8. And if you use a backboard, make sure to put padding or a towel underneath the shoulders to keep the patient in proper alignment. Because remember, their occipits, the occipits of children are bigger, and so you have to make sure that you pad to keep a proper alignment of the neck. Okay, so policy 8065 talks about hemorrhage control. The biggest change for this one is that we've added in TXA 2 grams rather than 1 gram. And now the TXA is going to be with a slow IV push rather than hanging it from a bag and letting it drip over the course of 10 minutes. Dr. Mackey has made a great video about the why on this.
Apologies for this interruption, but we have some breaking news.
Hey everybody, Kevin Mackey, Medical Director of Sacramento Fire Department, coming at you today. But hey, I have a special guest I want to introduce to you, Dr. Brianna Beaver. She's our EMS fellow this year from UC Davis. So Brianna, welcome to Sacramento Fire. Introduce yourself to the gang.
Thank you, I'm happy to be here. Hey everyone, I'm Brianna. I was born and raised in Redding, California, not too far away from here. I have gone to school all throughout the state of California. I went to medical school and then most recently did residency at UC Davis. I finished in June of this year and I've stayed on for EMS fellowship and I'm here with you guys for the whole year. Some of you I've met and some of you I haven't yet.
So many of you know that in the hemorrhage policy, the county just changed to 2 grams slow IV push. And I'm getting a lot of questions. We are getting a lot of questions both in the department and at the emergency department about why. Like, where did that come from? We've done 1 gram over 10 minutes for quite a while. And so why was it changed? And so I thought today we would bring you some of the answers to the why. So let's just start with the background of TXA. So Brianna's done a lot of the research on this already, so she's going to do most of the talking and I'm going to shut up. But so TXA kind of came to us through a couple of big studies, right? Can you just give us a little summary of kind of what you found?
Yeah, absolutely. So as many of you probably know already, TXA has been instrumental in the past 15 to 20 years with regards to hemorrhage and bleeding. bleeding. So in several studies, including CRASH 2 and CRASH 3, they have shown that by giving TXA, you actually have mortality benefit, meaning that more people stay alive and make it out of the hospital in a hemorrhagic situation when TXA is used. And so that has been extrapolated into the pre-hospital system, which is why pre-hospital providers started using it.
Right, that's a great summary. So we have military trials, which was MATTERS. We also have civilian trials, which is the CRASH studies.
Yep.
And CRASH has 1, 2, and 3, like you mentioned.
Yep.
And some of them are about traumatic brain injury, which is kind of CRASH 3. CRASH 1 was like the civilian hemorrhagic shock study. So we knew that there was a benefit to TXA, but there's always been a question about like risk, right? And so if we're going to talk about risk of giving TXA, what are some of the things that I think folks are concerned about, especially the trauma surgeons, the medical community, the firefighters? Like, what are we concerned about with TXA and the complications?
Yeah, absolutely. So TXA obviously is used to stop bleeding, but with that, it can create clots. And so some of the earlier studies and some of the earlier concerns with regards to risk were actually about developing clots that you didn't necessarily want. So that would be, you know, DVTs or other clotting events. And in addition to that, when they did early studies, they looked at different dosing patterns, and there was some studies that show that the faster you push TXA, there were also incidences of hypotension. So was the hypotension because of the TXA, or was it because this person was in a hemorrhagic shock event? And so some of those risks that Dr. Mackey's talking about are the hypotension, DVTs, and other bleeding events. And so those are some of the things that when they were doing the CRASH 1, 2, and 3, as well as other TXA studies, they probably used a lower dose being the 1 gram, due to those, you know, perceived risks or concern for perceived risks.
Okay. Yeah, so safety profile first, finding out that 1 gram works, but then this idea starts coming out, and we see a recent paper, well, not so recent actually, it's a couple of years ago now, I think, that came out of TCCC.
Yep.
So TCCC is the basic training for military, and they have started to escalate their doses to 2 grams. And in the TCCC guidelines, you'll start to see the talk about 2 grams. And so, is it safe to go to 2 grams? Have they looked at that? Are we thinking that there will be more problems because we're going to a higher dose? Have they looked at that?
They have. So there's actually been, over the past about 4 to 5 years, there's been several studies, including randomized control trials, that looked at 2 grams versus 1 gram followed by an infusion, which has kind of always been the standard. And they have shown that between those 2 doses, there's no mortality benefit in giving the 2 grams, meaning that amongst the 2, by giving TXA, you're not, you know, having a higher mortality risk with a higher dose, but they are showing that the sooner you give it and kind of over a shorter period of time, so that 2 grams IV push, you are actually, there was one study that showed you're getting a decrease in the adverse outcomes, such as DVTs like we talked about earlier, and then in TBI patients, they talk a little bit about cerebral vasospasm. So yes, I think that based off of the studies that there are now, right, research is always advancing, based off the studies we have now, 2 grams IV push over about a minute is totally safe.
All right, so the county's made a change. We've gone to 2 grams. We've seen that they've looked at the safety profile. It seems to be safer. Some of the questions I get from the field are, you know, before I could just set up a drip and I could just let it run.
Yeah.
Right, and now we're not doing that. Our hands are kind of tied up, right? But the other advantages to having the 2 grams in is the fact that I think you free up an IV line.
Yeah.
Right, to be giving medications or blood down the road, so it sounds like it's safe, and it looks like they're looking at least the TCCC group is looking at it more in head injury as well, traumatic brain injury. So I think we're okay. I think we're okay to proceed. It is definitely a change. So just to remind you, this is 2 grams, which is going to be 2 full vials. TXA only comes in 1 strength and 1 vial, so you're going to be giving 20 cc's. And how long should they give that over? Like, did they look at that too?
They did. So there's been a couple of different studies, not on humans, but other research studies that have shown, you know, TXA push over 1 minute, over 5 minutes, and they have deemed no difference. And so doing that that 2 gram IV push over about a minute is going to be a totally safe and appropriate amount of time. And honestly, I mean, you know, it's hard to say, but by the time you spike a bag, hook it up, you know, you're probably done with that IV push around the same time, and then you have a free IV line, you're ready to go, you have more hands, you don't have to worry what that drip's doing.
There you have it. We're trading off the time to set up the IV. In the time we're going to be doing that, we'll be given the push, and it'll be a wash. We'll be at about the same amount of time. All right. Yeah. Well, thanks. It was great to meet you.
Yes.
Great to introduce you to the crowd. And hey, be sure to send any questions on over our way. I will drop our email at the bottom of the video here. And thanks for joining us. We'll see you next time.
Bye.
Cool.
Sweet.
And now back to your regularly scheduled program.
The other big change for hemorrhage control is that we took out the isolated head trauma section. This is a good place to remind you that most head trauma can be controlled with direct pressure. So a fingertip, 2 fingertips, a hand, a palm. You may need some gauze or a quick clot for some larger wounds. Don't give gauze or direct pressure if you suspect a skull fracture. So if you see brain matter or anything like that, absolutely don't give significant pressure to that. Otherwise, most of these wounds can just be controlled with some direct pressure and a wrap. TXA does have other uses. So for poorly controlled epistaxis, oral bleeding, or bleeding after an oral surgery, you can consider calling for the base consult to get authorization for TXA utilization in these cases.
Okay, everybody, 2 policies together, policy 8062 and 9021. This is the adult and pediatric version of behavioral and crisis restraint. You'll see that the words have been changed around a little bit, and there's been a little bit of a change to the policy, but not much. But this one's pretty near and dear to my heart because this one can actually get us, you, in trouble. If I just want to harken back, if you didn't know about this, the Aurora, Colorado case, 2 firefighter paramedics administered ketamine to a patient in behavioral crisis with Aurora PD present, and that patient had a poor outcome. And as a result, one of those paramedics was actually charged with a felony and did some prison time, and was just released a couple weeks ago after the judge commuted the sentence, but was charged with a crime for taking care of a behavioral crisis patient. But there's some learning lessons in that case, which I won't go through here, but you can Google it. Paige Wolfberg and Worth has done a story on this, and actually their attorneys did a great job kind of dissecting the whole case. But there's some key parts of this policy that I really want to drive home. So let's get started with those. Okay, first of all, you do not have to engage a patient who you are likely to get injured with. Okay, there's nothing that says you are required to engage with somebody where you are likely to get injured, okay? You are to maintain a safe distance, and when possible, keep visual contact, request law enforcement assistance, document that you requested law enforcement assistance, and don't try to do any kind of maneuvers for takedown if it comes to that until you have enough people present. Okay, that's a little bit of a nuance of a change. The old policy used to say trained individuals, now it says enough individuals, okay? Document any delayed or no response from law enforcement. That's an important metric that the county would like to track as well, where you document that. There's no real procedure code for that, so you're gonna put that in your narrative. All right. Now I want to get to the meat and potatoes. I'm not going to go through how to restrain somebody. I'm going to try to help you keep yourself out of trouble, okay? First of all, most importantly, once you have successfully engaged the patient, if it came to that, and you restrain them with or without law enforcement's involvement, get that patient sitting up. Do not leave them prone. Do not leave them supine. If you don't believe me, try going on a few 100-meter sprints and then putting your hands behind your back and laying on your face or laying on your stomach. Okay, you will find out quickly you actually have a really hard time breathing. Okay, sit them up. Second of all, that's one thing that's gotten paramedics into trouble before. The second thing is start getting objective measures as soon as you can. If the patient's screaming and yelling still and fighting, you're not going to be able to get a lot of objective measures. That is your objective measure. They're screaming and yelling, right? They're maintaining an airway. However, if you've given medications or the patient's all of a sudden getting quiet, that's a really good time to start putting on a cardiac monitor, measuring oxygen saturations, measuring end-tidal CO2, whatever you can get your hands on to objectively measure what the physiology is with that patient at that time. That is critically important. That is also another common theme that happens when paramedics have gotten themselves in trouble taking care of a patient that was violent or having a behavioral crisis, is they didn't actually measure anything objectively, and they weren't picking up on when the patient was decompensating early enough until it was too late. Okay. Take the handcuffs off, replace them with commercial restraints unless they're under custody, and if they're in custody, that law enforcement officer has to go with you. Don't forget that. And then finally, try as much as you can to forewarn the hospitals that you're on the way in with this person who's pretty tough to control, all right? So they have enough people there to help, okay? I know there's probably other questions out there about this policy, but it's not really a big change, but I wanted to take a moment to really remind you of the key things that have gotten paramedics in trouble, dare I say even prison time, okay? And if you'd like to learn more about that Elijah McClain case, go to Page, Wolfberg, and Worth. You can Google it, PWW, and their attorneys have done a great job looking at the case. Ta-da! Okay, we're all done. Give yourself back. You made it through this. Hopefully you found some pearls in there and some things that are really going to kind of lift the game in EMS for you. As always, you can send questions to any of the medical directors. I'll put our emails here at the very end, and then also the county, of course, Dr. Can, if you have any direct questions about any of the policies. I hope this was helpful to you. It's really a labor of love for us. I'd like to personally thank my counterparts, Dr. Smalls, Dr. Nike, and of course, Dr. Sloan, for partnering with me and getting this done, and we will see you next time.